Let's see about type 1 hyperlipidemia. Type 1 hyperlipidemia is also called Familial Chylomicronemia Syndrome, is a rare inherited disorder of lipid metabolism. It is characterized by a marked accumulation of chylomicrons in the plasma due to defective clearance. Cause and pathophysiology. The condition most commonly results from lipoprotein lipase deficiency or from apolipoprotein C2 deficiency, which normally activates lipoprotein lipase. Without proper LPL activity, triglycerides in chylomicrons cannot be broken down and they remain in circulation. Inheritance. The inheritance of this disease is autosomal recessive. Remember, usually structural defective diseases are usually autosomal dominant and enzyme defective diseases are autosomal recessive. Since here the defect is in LPL, which is the enzyme, this disease is autosomal recessive. Lipid profile findings. The lipid profile shows very high triglyceride levels, often above 1000 to 2000 milligrams per deciliter. There is an accumulation of chylomicrons, giving fasting plasma a creamy, milky appearance. LDL and HDL are typically normal or low. Importantly, unlike other forms of hyperlipidemia, premature atherosclerosis is not seen. Now let's go through the clinical features of type 1 hyperlipidemia, also called Familial Chylomicronemia Syndrome. The most important and classic feature is recurrent episodes of acute pancreatitis. This happens because triglyceride levels are extremely high, and this can present as severe abdominal pain, nausea, and vomiting. Next, we see eruptive xanthomas. These are small, yellow papules that appear on the skin. They are most commonly found on the buttocks, shoulders, and the extensor surfaces of the arms and legs. Another important finding is lipemia retinalis. When you look at the fundus, the retinal vessels appear creamy white or milky because of the high triglyceride content in the blood. We may also find hepatosplenomegaly due to accumulation of fat in the liver and spleen. And finally, remember that the symptoms often appear in childhood. Children can present with failure to thrive, abdominal pain, or recurrent pancreatitis at an early age. So in summary, recurrent pancreatitis, eruptive xanthomas, lipemia retinalis, hepatosplenomegaly, and early onset in childhood are the hallmark features. Now, let's discuss the management of type 1 hyperlipidemia. The cornerstone of therapy is strict dietary fat restriction. Less than 15% of total daily calories should come from fat. This is the single most important step to prevent complications. We can use medium-chain triglycerides or MCTs. Unlike long-chain fats, these are absorbed directly into the portal circulation and do not require lipoprotein lipase for metabolism. It is equally important to avoid alcohol and simple sugars because both of these can markedly increase triglyceride levels and trigger pancreatitis. Now, what about medications? Conventional lipid-lowering drugs such as fibrates or statins are generally not effective in this condition because the enzyme defect is absolute. Finally, remember that newer therapies are under research. These include gene therapy for lipoprotein, lipase deficiency, and drugs like apolipoprotein C3 inhibitors, which may help in the future. So, to summarize, strict fat restriction, use of MCTs, avoidance of alcohol and sugars, limited role of drugs, and upcoming gene-based therapies form the main management plan.